Well, hello, everybody, and welcome to the Advocate Health Advisors podcast, the AHA podcast. Current topics and current insights for you. We're going to start off today by talking to Jennifer and asking her about advocacy. So, Jennifer, what are you hearing from our brokers in the field about advocacy these days? It seems to be a topic.
It is, yeah, I know. It's so many changes going on, and the agents are really concerned about their commissions, right? And some of the things we've seen coming from carriers that's unusual, especially if you've been in the business for a really long time. And so, of course, that brings up like, how can I get more involved and have my voice be heard? And I think we see a lot of different organizations doing great things, right? We have NABIB that is got local chapters, NAFA. There's a couple of new ones I've seen out there. There's some different folks, out there trying to speak to CMS about what's going on. But what I would say, in my opinion, at the end of the day is, if you want to be involved, you should be involved. And there are so many different organizations doing things, and you should pick the one that's right for you. And so, the first one being NABIB, I really like what some of the local state chapters are doing. Some of them need a little bit of assistance with more leadership, but there's a few states where we've got agents that work closely with Advocate, and they're doing wonderful things to help agents. So I would encourage agents to get involved with their local NABIB. As far as if you're like an agency owner and you've got downline agents and you're concerned about, administration and things like that, and how the different levels of FMOs play a part, then I really like the work that's being done through NAFA that Darwin, you're involved with that Medicare collective. And so every single agent out there who works up through a hierarchy, there's somebody, even our competitors, involved in that council where we're talking and getting in front of CMS and doing good things, which I want to hear you talk about a little bit, Darwin. And then, there's a couple new people out there I've seen creating different advocacy groups, so get involved. Maybe also talk to your local congressman if you feel comfortable about what you do in your community. So I'd love to hear, Darwin, what you think too, because, you're very heavily involved in Jacqueline in the Medicare collective and what they're doing.
Yeah, so I agree, Jennifer. We have to have our voice heard. There's many ways to do that. I think the emerging organizations will bring a lot of energy. I think that you captured it properly. The NABIP, they had some senior leadership challenges, but overall, their grassroots and local campaigns carry on, and that's we need lots of voices. So it's not. I would encourage both NABIP and NAFA. So I'm a member of multiple things. The Medicare Collective is probably the biggest news. The top FMOs have gotten together. My peers are very well versed in the industry, and Jacqueline helps me there. We literally go together, work on top issues and messaging. Have sat in front of CMS senior leadership at all levels of leadership. Have another conversation. So really, for the first time, there's a conduit for the industry to have a voice, not the carrier speaking for the FMO or the broker, and not the broker speaking directly to say NABIT, but the leadership team collectively, which is good because then you get the whole story. And we are really a consumer protection. So the way that we've got the system set up now, an individual client kind of has a hard time trying to deconflict a disagreement between a provider and a carrier. But now with us working the way that we do, we can not only help deconflict provider payer conflicts or appeals, we can also give insight on best practices to CMS so that CMS can work with the carrier, not overregulate on the CMS part, but share best practices among carriers. So that communication and collaboration is really good. And so thanks for bringing that up, Jennifer, because we didn't have that. And the other thing you said that's really important is that to the extent you're comfortable, you really do want to go to your local congressman. There's 435 people in the House of Representatives. There's another 100 senators. The Congress people in the House are very approachable. And think about it, you have easy access to how many of their constituents are Medicare beneficiaries. They would love it if you showed up, let them know what a quality broker and the service we provide and the help we provide, and offer to help their staff. They get phone calls all the time about Medicare, Medicaid, and things that we know about, and so you can be a resource for them. So thanks for that, Jennifer.
Yeah, that's awesome. That makes me think about, some of the concerns and the reason that we're all worried about getting in front of these organizations and getting in front of CMS is because some of the things we see carriers doing right now with commissions, right? And that gets agents really concerned. And we talked about that on our last podcast, if you didn't tune into that one. But, it's probably relevant to mention a little bit more about that related to, again, we think we're very bullish on Medicare Advantage and going forward. There's a lot of people that need to be helped, right? We have what is it, 35 million people on the plans and growing, and so we feel like it's going to continue to grow. But that gets into, the what carriers want to pay for. They want to pay for the quality. And so, you see some carriers paying a little bit less for PPO versus an HMO or cutting commissions or things like that. But ultimately, what going into 2027, crystal ball, but I feel like we're gonna see carriers wanting the, things to align with their bottom line, I guess, right? So we feel like we're going to want agents to put quality enrollments together, and those 5 metrics, and also they're going to start holding the FMO organizations like Advocate and others accountable for delivering those great metrics and paying them accordingly. So if they're bringing in good accretion rates, Alyssa, you heard a little bit about this. Maybe you can share like more details on what they're gonna be looking to see us all do.
Well,
Yeah,
before she gets into that, I wanna kinda, bifurcate. I wanna put it into 2 pieces, what you said, Jennifer, and I agree with everything you said. So first of all, there's been a little bit of a knee-jerk, reaction because the previous administration had a bunch of things that they, put into place, and then, some of that in the IRA is still coming out now, and next year, the other shoe's gonna drop with yet more drugs and more of things being mandatory. And so that put more than margin compression that caused health plans to be unprofitable. Now the plans, they can only take back benefits to a certain level. So they don't want to cut commissions and everybody wants stability, right? So some of this is just working out the kinks and the bumps in the system that were put in place some time ago, kind of like ripples in a pond. If the carrier isn't paying a commission, it's because they don't want you to sell it, and it's likely that it's going to go away. So it would be disruptive to put someone in one of those plans, even if it seems like a good idea in the short run, because it really takes a couple of years to stabilize. The way that pay works and the way that the well being of the beneficiary works is that stability is best. It takes doctors time to get a handle on things, to get the meds right. It also takes time, for the system to compensate and align the incentives. So that's kind of the past. So when we do need to be mindful. When we spoke with CMS, they weren't aware of that earlier this year and how that was impactful. But going forward and stability, we know value-based care. We know that carriers want us to use the networks of doctors that are higher rated, that do better, that perform better, and that's good for everybody. So what they're doing now for the first time, which is ultimately positive, it'll probably be bumpy too until they get it right, but they're looking to have more prevention versus cure and to align incentives. So what I mean by that is the administrative fee now isn't just a flat fee, no matter what your retention, no matter what your accretion, no matter what happens with the outcomes. And that's appropriate because we're a part of the value stream and we come first in the equation. So we have a really valuable role in educating and expectation setting and, breaking down walls, filling gaps. And as we do that, that comes out later in outcomes. And so, you see a lot of noise about the broker malfeasance, but that's just a small percentage, and it's easily cleaned up. The real exciting story is to talk about how we impact outcomes by using the preventative nature of the business and those 5 quality metrics, which I'll ask Alyssa to talk a little bit about that. That represents other things, and then Jacqueline, after Alyssa goes, maybe you could talk a little bit about your experience in the provider world and how the MSOs and the primary care doctors have so much pressure in such a time frame and how we can help them. So first Alyssa, then Jacqueline.
Yeah, I was thinking of a couple things when Jennifer was speaking. So, one about getting involved in advocacy. I totally agree about the local advocacy, starting at a local level, whether that's going to your, annual Medicare symposium from NABIP, which in Florida, where we are, that's happening in Orlando this summer. So, getting involved on like that local level might be less intimidating than perhaps jumping into a nationwide level, and just telling people what good agents do, I think, is so important because I think sometimes good actors get lumped in with bad actors. So I think the more that we can talk about what a good agent looks like and what they do for their communities, I think is huge. And then again, what
And how we
you,
measure it, right? And
that's
how
right.
we can actually measure it.
That's right. How we measure it. And so that goes into obviously, quality has been a hot topic in the Medicare space with CMS and with the carriers, quality brokers, quality enrollment, stability, those all go hand in hand. And I think the carriers obviously want to reward good quality and also impact bad quality too. And I think one of the things that they are putting a lot of weight on coming up is going to be rapid disenrollments, which is when somebody comes off a plan within the first 3 months after the enrollment. Somebody, there might be a legitimate reason for why somebody would drop off a plan in the first 3 months, but often it's an indicator of not doing a thorough needs analysis, not the goodness of fit for the plan to that member. Maybe a provider wasn't in the network that should have been checked and, could be just something that happens, but it's definitely an indicator. And I think one that's going to be looked at more closely and one that we're definitely going to be working with our agents on. Of course, there's other indicators like complaints to Medicare, complaints to the plan, accretion rate, which is when a plan gets accepted or not when it gets submitted to CMS. So those are some of the things that we're going to be putting an emphasis on because the carriers are also rewarding good behavior and impacting bad behavior.
Well, and you make a great point there in that there are it could be a sign, but it could be legitimate. So
Mhm.
we have to protect the brokers and make sure that CMS doesn't go on a witch hunt. Complaints to Medicare right now are 90% not founded, yet they sort of look at the carrier the same way as if it were founded. And then the definitions for a complaint to Medicare are pretty broad. I think that the five lagging indicators of quality are really important because there's a perfectly legitimate reason to have a rapid disenrollment because there could be a service area reduction.
That's right.
Also, there's a perfectly inappropriate way that you could put someone on a plan who doesn't have an oxygen benefit because you didn't do a proper needs analysis. You slam them into that plan inappropriately, whether it was malfeasance or incompetence. You just didn't do the job the right way, and then that person ends up with an $800 bill 3 months later and they disenroll, or 4 months later. But when you take all five metrics in totality, you really have something that catches your eye that warrants a further conversation. Now, in speaking with the carrier leadership, it's important to make sure it's not a broad brush measure. So you can't measure all plans. If someone focuses on DSNP, they're going to have different metrics. So the metrics have to be the same metrics, but they have to be applied by plan type, PPO, HMO, et cetera. And also, what's really important about that is that even though the carriers are moving towards, a quality is king mindset and they're connecting the dots now, um, there isn't a consistent yardstick for them to use. So what they're doing now and the different people I'm talking to, they've got good metrics in place, but they're unique to them. And so what I'm echoing and asking the carriers and CMS, and I'm getting a lot of good feedback on, is I'm asking them to, help us define what those five measures are, have parameters, and then have an internal look, just an internal look, so that they can see. That'll stop the broker who is bad going from one carrier to another. They get terminated, they go to the next one, the next one. So having a yardstick that kind of can measure brokers across carriers, and even, one day maybe use that if you find an allegation is founded, we could let the OIG know, or take away the privilege, but that would be an isolated case. Mostly it would simply be you're in the parameter. If you're not in the parameter, we want to coach you up. Remember, about 80% of what you need to know to be a real professional in Medicare Advantage isn't taught on AHIP and it's not taught on the state licensing exam. So there's so much institutional knowledge that's tacitly transferred in a sort of a mentorship way or when you're a journeyman, or apprentice type model.
Mhm.
And it takes years to build that up. And so part of the problem in the industry is that we don't have a good way to measure quality. So we created the lagging indicators of quality so you can see where your attention should be drawn and you can have a measure across carriers that's useful. Now, there's still best practices on the front end of that we want to share, and that CMS and their oversight program would be able to cross pollinate best practices of how the carriers work with the FMOs and how the FMOs work with the brokers. And Jacqueline and I are actually writing a guide now to try to be an industry, guidebook, if you will. With that, I wanted to pass it over to you, Jacqueline, to talk for a moment about the model in terms of how we help the MSOs and the primary care doctors and the value that we add to them. And then any insights you're seeing for some of the current studies that are out.
Yeah, I think, the first thing that came to my mind while you're talking about, the quality metrics too, there's a recent study this week that came out that looked at face value, the amount of commission trends happening in the MA industry in particular. And over the last, 10 years, the MA population has more than doubled. And I think there's a real appetite to look at what are we getting, when we implement the use of brokers in the MA space. And I found it, really insightful, to look at the amount of renewal commissions out there and how that's a big chunk of broker commissions. And I think that speaks for itself. And we're happy to help those researchers, I think, connect the dots to the bigger picture of how that really plays out in the space for quality. Because we know if a member stays on a plan and has that longevity, and hopefully we're seeing some more stability, that usually the broker did a good needs analysis. And if they're staying on that plan, it's because the broker is providing ongoing service and helping them unlock benefits, access care. So I think there's an appetite to understand what are we getting for that? What's the value on that
Well,
too?
I want to interrupt you there though, because I thank you for sharing that study. I read that study and I agree with everything you said, but I also feel that it's a little bit uh, short and not quite going far enough because it just talks about the billions of dollars of commissions, but it doesn't
Hmm.
really explain that healthcare is a $5 trillion industry, and so the proportionality of it, it still it smacks of the MedPAC kind of legacy and it isn't as illuminating as I would like it to be. But I agree with you that good on them. There's an appetite for that, and they took a step forward and they acknowledged in other things. And so I think that definitely I got my doctorate and wrote my dissertation on broker quality in the Medicare Advantage industry because I saw the dearth of information. There's just not information out there. One study I saw, it was a 10-year study involving tens of thousands of Medicare beneficiaries, and they were wondering why they disenrolled. And nowhere in the study or nowhere in the suggestions for future studies did they mention the broker as something, to consider or talk about. And so I definitely will follow up and work with them because, the data should show how much in commissions, but then we should show how much that money impacted wellness on the 85 cents in the medical expense ratio because we're unique. Prevention beats cure, and Medicare Advantage actually keeps people healthier. Better American Alliance has great data on that. Dr. Oz and Chris Klomp and the whole team over at CMS has said in public that they want people in value based care. They don't always use the value based care. They said Medicare Advantage and ACO specifically. That's what John Brooks said. That's what Chris Klomp has said. And it's true, right? The metrics are there. So go ahead, though. I didn't mean to interrupt you.
Exactly, Ed. And so in terms of, having that stability of relationship with the broker, talking back to about primary care providers and some of the really important things, that we can do to first help our clients and members be healthy is number one, to go to their annual wellness visit. Millions of older Americans don't go to the primary care provider, and that really has, negative consequences not only for their health, because oftentimes a lot of conditions start out non-symptomatic. So usually, when symptoms start, people usually go to the primary care provider, but it's really important to do the preventative things to stay healthy. And I think, that's where we see us having a role in helping them get into the door. If there was only one thing that we could really hone in on there, a lot of that will take care of itself. And the reason why is because, this relates back to the plans and how they're funded and the stability too. When a member is in a plan for a year. It takes time for the health plan to really understand that member, to document their conditions and to take care of them, and to prevent unnecessary emergency room visits. So us helping the members get into the doctor's office really does a lot of work there. There's a lot of star rating measures that are also impacted by the work that the providers do. So a lot of the star rating measures that you see for health plans, a lot of that work is done by the primary care provider that shapes those ratings, and it's contingent on them getting those preventative care things done, like mammograms, colon cancer screening, blood pressure monitoring, and all of that. So it really does um, come to the plan, the provider, and then the member. So it's a whole wellness set that benefits everybody.
Yeah, and it's hard to believe it was worse in the past, but still to this day, 200,000 people a year die from what they call medical errors, but they're really not medical errors. They're missed prevention opportunities, they're administrative errors, maybe the wrong code got on the wrong chart, coordination errors. Um, the things that happen that are preventable are really well resolved by Medicare Advantage. And Medicare Advantage is inherently, they used to call it managed care, right? It's the whole coordination component. And that's why it's so good. As far as, and it's hard to understand how something could be so impactful. But if you think about catching a metric before it's a symptom, or catching a symptom before it's a disease, just take type 2 diabetes, right? So that's a disease. And before you're type 2 diabetic, though, you have key metrics, and they even have a name for it. They have metabolic syndrome, they have pre-diabetes. They're looking at the early indicators that lead to diabetes, and they're giving you a chance to intervene. Maybe you have a symptom, but they can fix that. Diet, exercise goes a long way to really impacting that disease. And so if you're getting your visits and you're taking action and you're active in your health and the benefits of the plan, you prevent chronic conditions. And 68% of the population over 65 has one or more chronic conditions. And so, that's a hard to comprehend, that it's so real that prevention beats cure and how that plays out into people's lives. But on a lighter topic, though, Alyssa, what are you hearing from the agent care team?
Oh, so we're getting a lot of questions as far as what we're going to see for 2027 already upcoming. We've heard about a little bit of expansion from some carriers, but just given the past year, I think some agents are just wondering, like, if we can look in our crystal ball and see, kind of predict what we think is going to happen for 2027, which, we can't. We'll be getting some more information here over the summer, so we'll have more to share there. But our agents are so awesome because they just continue doing great stuff that they're out there doing. So that's kind of the message that we keep sending. Just keep doing good and the good's going to come back, and it's going to be a great AEP. Like, there's so many people, as we just talked about, the opportunity is so big. I think the carriers are coming out with more and more like chronic condition plans, like you were just talking about. I just did a training today on CSNPs, what they call chronic condition plans, to educate, because I think that's just going to be something that we're going to see more of, that disease care management and plans that are tailored to those conditions to help people get that specialized managed care. So, yeah, the agent care team is doing a
It's
great job.
awesome. Well,
Yeah.
yes, you are, and I'm glad you got Advocate University in there too.
Mhm.
That is the future. And those chronic condition plans, that's like concierge medicine for everyday people. You still get the MA pricing preferences and benefits, but it's a whole care team, and it's really, really well done. And quite frankly, that's an evolution of the system. And you might not know this, but Senator Ron Wyden, it was his office that was a champion of that chronic condition plan. So it's really cool to see things work their way through the pipeline that benefit. And we're coming up on 1 million people enrolled in chronic conditions. So that's a good job to everybody who got that done. So Jacqueline, why don't you take us home and give us a client care team success story in the last bit of time. Tell us one of the many wonderful stories that you have, and what type of situation you resolve.
Yeah, absolutely. So we've resolved client um, sticky situations every day, and they vary from everything that they use in their plan to even accessing community resources. And I think a lot of agents, because we're going to be in the second half of the year soon. So I think a lot of the agents might see this.
Hey,
And
AEP is coming, huh? Yeah.
yes, it's coming, and we're actually preparing for the ANOC season right now. The client care team, we're updating our book of business communication catalog because it's going to be very busy for us here in the next couple of months, helping agents prepare for that book of business communication. As we head into the second half of the year, something that just comes to mind because a lot of the benefits that are allotted sometimes in plans can get exhausted as you hit the third quarter or fourth quarter of the year. So I picked this one on purpose because there are great resources out there that this is an example of what brokers do every day and the client care team helps with. Every year around this time, we get some of the members. Speaking of CSNP plans, which are wonderful, many of them include transportation benefits, and that's not by mistake. Because a lot of times, if you have diabetes and you need to go to dialysis center for routine treatment, transportation is really valuable, especially if you live alone or in your rural area. And so we recently helped a client, a Medicare Advantage beneficiary, who called into us and she let us know that she had spoken with her health plan to coordinate a routine transportation to a dialysis center. She was informed that she exhausted her transportation benefits. So she called us and literally said, I plan to call the ambulance to just go to the emergency room to get my dialysis because I need it. It's very important that I get it. I go about twice a week. There's several weeks left in the year. So that's maybe 14 plus ER visits that I'm okay doing because I need to get this done. And that's really hard to hear that. And she lives alone, doesn't have transportation. That's when our team actually used findhelp.org. It's a great resource, has a lot of community resources. You can look up by zip code, has everything from transportation to food pantries, to even social workers in there. You can find a lot of great information, especially for seniors in their community. And we found a local transportation services for older adults to medical appointments. We got her that appointment that day, and she used them the rest of the year to cover that gap. So no
Wow.
ER visits for her.
Wow.
And she
That's
she called us. Yeah.
amazing. Good job. And that not only touches your heart. Dr. Oz says that 1 in 4 emergency room visits on average ends in some harm. And he said that's the worst kind of care because not only did you do the harm, then you have to undo it. And that doesn't even consider the other things that can happen in the emergency room with bacteria and the things. And not to disparage the emergency rooms, but those are some national averages that he socializes. And so, those are potentially life-saving things. And plus, not only the cost and the risk, it's just a lot better for her to be at the dialysis center and to go that way. That leads me to one final comment. I was at a event recently, and I met someone in the state of Florida who's in the transportation, and he was head of transportation and safety and had a healthcare in Florida. Because of the interstate system, the emergency services are under Department of Transportation. in some fashion because of the ambulances being dispatched. What he told me is that there's actually a state level policy in Florida where the ambulance visit can't get reimbursed if they don't go to an emergency room. So I'm going to dig into that more, but it's interesting the role that policy plays. And I don't mean to be factually correct or incorrect here, but he was just saying that if they could just go to urgent care or a better, better triage the level of care that's needed, that might make things work. I think Medicare Advantage has worked out some of the kinks in that, but it's interesting to see how we can work at every level, at federal, state, and local level, for the betterment of the industry. Well, thank you, everybody. I can't believe the time flew so fast. Look forward to talking to you all next week. And thanks again for listening to Advocate Health Advisors podcast, the AHA podcast.